My name is Brendan. I'm the COVID-19 lead from the Adelaide PHN. Welcome to tonight's webinar for the primary healthcare COVID-19 update for the primary healthcare providers. I just want to first start off by acknowledging the Kaurna peoples, who is the traditional custodians of the Adelaide region. We pay tribute to their physical and spiritual connection to land, waters and community, enduring now as it was throughout time. We pay respect to them, their culture and their elders past and present. Welcome, thank you. We've got a special guest tonight, so I'll hand it over to you, Emily, to introduce the special guest and tonight's proceedings.
Wonderful, thank you, Brendan. Before we start, I'm just checking that we. Hold on. I'm going to get you to mute, Brendan, if that's okay. Perfect, excellent. I think everyone's just joining now through the system. All right, fabulous. So thank you, and a very good evening to everyone who's joining us tonight and who will join us online in our recording later. First of all, I'd just like to acknowledge the land in which we're meeting here today, and for me here on Kaurna land, and pay my respects to elders past, present and emerging, and thank them for the care that they've provided to this wonderful, wonderful country that we live in today. I wanted to first of all welcome our two special guests today, as we don't often have two fantastic speakers joining us outside of our COVID team. So we have Professor Katina as Professor of Prevention and You're Executive Director of Prevention and Population Health at Wellbeing SA. I had to get that right as I said that. I had to think that through in my mind from the last time you were with us, and it's fabulous to have you, Katina, with us this evening. And then we have Dr. Tom Goddard joining us as well from the Women's and Children's Hospital as a respiratory physician and sleep medicine specialist consultant at the Women's and Kids. And we're delighted that that Tom's joined us tonight to talk through around what we are seeing from a respiratory point of view in COVID, but also around some of the emerging presentations with PIMS TS as well, which will be really interesting to hear about further. So I'm going to first of all provide a brief COVID update on some of the key areas that we just wanted to talk about tonight, and particularly where we're seeing some of the modelling and the cases increasing a little bit in the last few days. We thought this would be quite pertinent for our GPs listening tonight. So I'm going to share my slides. Which hopefully will come up now on the screen. Hopefully you can all see that.
Yep, I can see that.
Excellent. Okay, this would have been helpful if I had this slide up before when I started. Okay, so this is our webinar number 6 for the year, which is wonderful. I think this is probably webinar number 35 or something like that now we've come to over the past 2 years that we've been giving out to GPs. So I'll start with a quick community update, and then we'll progress to Katina and then to Tom to give us an update on some of the key areas related to vaccination that we're very keen to address tonight. So just in terms of COVID cases here in South Australia at the moment, and this is the data from the beginning of the week. So generally we report on a Monday where some of our data is currently sitting from a community response perspective. And we have Health Direct providing the majority of assistance now to individuals in the community through the National Coronavirus Helpline. So when we think about Health Direct, there's the Health Direct number that people call up if they're wanting assistance from one of the nurses to then know how can they escalate their care, or should they go to emergency department, and you can call up that Health Direct number. If you are COVID positive, they will redirect you to the National Coronavirus Helpline, which is the contract that we have in place between SA Health and the National Coronavirus Helpline to provide support and assistance for people who are COVID positive in the community. Anyone can call up that number. You don't have to be COVID positive, but if you call up Health Direct, you will be redirected through to the NCH number. And so we've had now 27,000 calls through that particular phone assessment, with 5,250 clinical assessments for the beginning of this week. And it's only really been since the 28th of March that we've had patients calling up Health Direct for clinical assessments, when we stopped having a public-facing COVID response care team phone number. And we've had now over 5,000 referrals for outpatient disease-modifying treatments, which is a fabulous number of referrals. And we will see that number probably won't increase too much over the coming weeks now that we are able to prescribe out through Paxlovid and Molnupiravir, and we'll have a prescribing webinar in a couple of weeks just to talk through some tips and tricks for managing the prescribing within general practice. From this week, we have now started seeing Paxlovid out into community pharmacies, so it should be really a smoother transition now and not requiring patients to be referred in through that online system through to our COVID care centres. And we had 25 patients admitted to the ICCNet virtual monitoring at the beginning of the week. So still very low numbers through ICCNet. So again, a reminder that if you are assessing any of your patients who are COVID positive, they can be referred very easily by completing the online form through to ICCNet, where they'll be sent out a monitoring kit with a tablet device, blood pressure cuff, temperature and oxygen SATS probe, and they'll be able to be followed up by the nursing team through ICCNet, which links into our virtual care service across SA Health, so anywhere in the state. So a reminder, very low numbers still being referred to that system. And then this was just those who were tested positive in the last 24 hours, which is how our reporting comes through. And we're consistently starting to see that increase now in patients over 65 years now, as we saw those numbers much lower in February, March. We're now seeing them go back up again, and particularly our aged care facilities, with over 130 aged care facilities currently have active COVID cases within South Australia. Just in terms of the modelling, and I'll just quickly mention as well around influenza respiratory panel testing as well that's coming through at the moment. So this is the publicly available modelling through Adelaide University that's on the website, and this is from the end of April, 25th of April. We don't have new publicly available modelling out yet, but I think hopefully next week we will, that will be available just to track where we are seeing some of those cases. So you'll note as well that we're at nearly 5,000 cases today, which is quite different to what the modelling is showing us. So that will be factored into that modelling for next week. As we see as well, we are noting now influenza cases in the community, and we've exceeded now the cases that we've seen in the past couple of years for influenza. And I did have the numbers. I'll pull them up in a minute and I'll post them in the chat around the numbers that we are seeing. I think it was over 400 cases now of influenza that we've seen this year here in South Australia. Now, this is the GP respiratory panel testing that's been ordered. You can see here on this chart here, we're still running that as a 12-panel PCR respiratory test. So someone can have that form, go to one of the drive-through clinics and have that test performed. So they can still turn up to a drive-through testing site, but they do need to have a GP referral with them for the respiratory panel, or it can be taken within your clinic if you've got a designated space in the car park or at one of the GP respiratory clinics as well. And we have noted that we're seeing that increase now of influenza A being reported at 26% of those tests coming back as influenza A. We're still on track with our quadruplex testing. I think I've mentioned that in the previous webinar, which will have the influenza A, B, RSV and COVID as part of a combined screening tool. We're just still working through what that means nationally though as well for testing for high risk groups, and who will be able to access those tests, and will they need to be referred in by a GP, given the implications for both reporting and following up of influenza testing. A little bit different with COVID, that's sort of just been absorbed into the CDCB COVID operations team that they then take on board through Nicola as the referrer. As many of you know, if you go to a drive-through testing site, that's who's on your Professor Spurrier's on your testing form. So we're just working through now what that means for influenza and that GP referral as well. Hospital capacity has gone up by 1%. So we haven't seen a significant increase, but it has increased just slowly. But over the next few days, it'll be very interesting noting now that we have nearly hit 5,000 cases in the past 2 days. And the ICU trends, it's a little low at the moment, the occupancy in ICU, which is good. It's lower than where it was previously, but unfortunately we have had a few deaths in the past week in ICU, which may account for some of those changes that we are seeing. But it has been a significant change, noting that we are sitting at 4 ICU presentations at the RAR as of yesterday, which is much lower than where we've been previously. So that's good. And we're still admitting in the country LHNs in the regions at the moment as well, and obstetrics has now resumed in regional LHNs. In terms of where the occupancy was predicted to be, so we were sort of sitting in that higher area that had been modelled through the University of Adelaide, but of course we've exceeded that now, and we're sitting at 4,299 cases yesterday, nearly at 5,000 today. So we expect that the hospital occupancy may change a bit over the next week, and we may see an increase in hospital occupancy higher than where we are at the actual numbers yesterday as 189. In terms of, and I show these graphs every time, in terms of, this is the work that Professor Joe Varney had been undertaking for us at, in the ICU at the Royal Adelaide, mapping the actual case numbers coming through, and then comparing it to the University of Adelaide modelling, and again demonstrating just sitting above that high prediction line for both hospital occupancy and then significantly for new cases. We had a fantastic presentation today to our Primary Care Task Force, where we have representation for the AMA, RACGP, the Rural Doctors Association, and ACRIM as well. And we had a presentation from Professor Spurrier today around where we are seeing some of those cases increase, and particularly some of the changes that we're noting now with close contacts. It's not that surprising that we are seeing that increase in cases in the community, but fortunately not at the level that WA have been noticing. In terms of variants of concern, and I'm grateful to SA Pathology, of course, Dr. Tom Dodd is no longer in his role as Clinical Services Director. So we usually have had Tom at these webinars, so we'll have to ask Dr. Sophia Otto if she's happy to come and speak to our webinars. And I know Ivan Bastian's also offered as well. But you'll note here the most recent variant of concern report that we had come back, we're now sitting at 100% as being BA2. In the most recent genomics form, but noting it's a very selective sample, international travellers and hospital presentations, with a few in the community added into that mix. And SA Pathology are working to increase their ability to undertake genomic testing on a wider sample of patients. Because at the moment it's sitting at around 250 per week that they're undertaking sampling on. Vaccination intervals, just very quickly, a target advice changed recently around the vaccination intervals, and particularly affirmed the advice that that all people should wait 3 months after a confirmed COVID-19 infection before they receive their next dose. So we had previously put out that advice, but it's been confirmed now through a target, and the next scheduled dose should be given as soon as possible after that period of time. And the other target advice that had changed was around the interval between the 2 doses, between the first and the second dose for an mRNA vaccine, with that advice previously being for 3 and 4 weeks, is now changed to 8 weeks between the doses, noting the improved effectiveness that's been reported. So that's the other advice that's come out from the target. And that's all from me. Very brief update of key areas, and hopefully that covers the key questions that we've had come through in our GP liaison email. Actually, I tell a lie. There is one more slide I just added in just then, which was reinfection within 12 weeks. And this was based on what currently we're doing at the moment. Now, this is what how we're currently managing reinfection in the department in SA Health. But we are looking to put out some more clearer advice, because this is really quite a frustrating area at the moment for many GPs, is around this issue with reinfection. And we've certainly seen reinfection at over 500 confirmed reinfections now within the 12-week period here within the department. So it's just interesting to note that we are noting, first of all, that there needs to be some sort of pathway or decision tree for deciding whether to retest people or not, and what that risk is. So at the moment it's around, if people are in low risk of transmission and have low or no epileaks, then the advice has been to isolate and not to retest. If someone has a low risk of progression to severe disease and an epileak, so say they're a household contact of a COVID case, and it's been more than 2 weeks since they've had a COVID infection that developed new onset acute symptoms, advice has been to progress to undertake a RAT, and if the RAT is positive, then to progress to a COVID PCR, looking at cycle threshold and to see whether it looks like it's a new infection, and then genomics. And then the third option is if someone is a high risk of progression to severe disease, so say they would be someone who'd benefit from treatment or working in a high risk setting, then suggestion again is to complete a RAT test, and consideration could be given then to progress to a full respiratory panel PCR as well. So that's just the current decision making. This is not formal guidance advice that we put out publicly, but it was just more that we've had lots of questions around this, and we're hoping to get formal advice out once we get that signed off, and Nicola was very supportive of this approach. I think that's all for me. So I'm going to hand over now to you, Katina, if that's okay, to give us a an update and run through around the key areas you want to focus on with vaccination and uptake. Thank you. I'm going to stop sharing my screen.
Okay, so can everyone hear me okay, and is my screen sharing properly?
Perfect, thank you.
Good, thank you. Thanks very much. That's all very interesting. Lots of interesting new things going on. So I'm going to talk about a little bit of more on the epi side, so I won't cross over too much with Emily, but really just talk about the vaccines for children, raise a couple of key common concerns that we're really hearing repeatedly. And I also just want to touch on again the style of communication that we know has the best evidence for effectiveness with people who are vaccine hesitant. So what I was trying to represent with this slide, and this is basically cases since November 23 and 2021, is that we now have a very large proportion of children and young people who are infected. It used to be that the curve would look something like that. So this is really quite a new transition. So at this stage now, on estimates, we have around 35% of children 12 to 18 who have become infected, and for 5 to that younger age group is around 30%. So it's really quite substantial. It's much higher proportions than it is for the adult population. So this is the curve, and obviously this is actually an epi curve presented not as number of positive tests per day, but rather the date of onset. So it's kind of a more formal curve. It is the case that at this sort of part of the curve, we were seeing massively reduced testing, and that really does contribute to what the curve looks like. And obviously, we're now seeing it starting to rise. But I do think that, really for many weeks, we've had relatively low testing rates in the community. This really just reflects what Emily has already said about the BA2 infection taking over. I guess the thing is that we do have other variants around, and so BA4 and 5 have been kind of taking over in other jurisdictions. So it looks like even when this wave is over, there may well be another one hot on the tails. So in terms of vaccine uptake, for children, we have a 59% first dose vaccination proportion and 41% second. For Aboriginal children, it's quite a bit lower at 38% and 21%. I guess the really important thing, though, about the graph that I've shown there is that, it's been in a plateau for quite a long time. We really have very low numbers of new children being vaccinated. It is the case that we, from an Australian perspective, are actually doing quite well. And from an international perspective, these proportions are actually very high. But it is starkly different, of course, to the general vaccination rate, where we're at 95% first dose, 93% second dose for the general population. So I did want to spend a moment going through these data. It's actually quite difficult to dig this stuff out, and it's really only getting published more recently, basically the vaccine effectiveness against Omicron variants. So what I've tried to do here is find specifically for the 5 to 11-year-old age group, and it's actually tricky. I do have reasonable data that I think has a reasonable quality that suggests that for symptomatic disease in adults, that we have that reasonably high protection against symptomatic infection at around 65 to 75%, in the first couple of weeks after vaccination, which basically over the next 3 to 4 months comes right down to around the 10% mark. This, of course, is something that people can see for themselves, that we obviously have a highly vaccinated population. We still have large outbreaks. In fact, for children, it would appear that all of those numbers with Omicron, we can just reduce them. I'm afraid I don't have precise figures for you, but every study that I've read actually has the 5 to 11-year-old effectiveness slightly less than the adult. In terms of risk of presentation to ED for children, it's around 50%. But in terms of reducing risk of hospitalisation, it's 68 to 74%. So I guess the point really here is that as with adults, children have a variable and really kind of reasonably short-lived benefit of the vaccine against catching COVID infection, but actually the benefit for severe disease holds. And it is an important point to make with people, because one of the most common reasons why people say that they don't want to vaccinate their children is because they have a belief that it is, common and mild. So yeah, I think it is, and the other reason, of course, that the vaccine's not working, and so they don't bother. I've got this slide up because I know you all know what this means, but you're welcome to have this slide actually. I find that it's a really helpful slide, especially if I'm trying to have a conversation with someone about what do those numbers really mean, because we might say a vaccine is 80% effective to the community, and they may not, but actually not really know what it means. And this slide I've taken from the WHO site, and basically what I do is talk people through an unvaccinated group being the same size as a vaccinated group. And if we're talking about an 80% efficacy, let's say against hospitalisation, that the unvaccinated group will have 10 people who are hospitalised, whereas the vaccinated group will only have 2. I find that it really makes it quite concrete for people, and they can see the stark difference between the vaccinated and unvaccinated. So the point I really wanted to make on this slide about the vaccine for children is that it has been given to very large numbers of children worldwide. It's also been given to a large number of children in Australia. And what we're finding is that the side effect profile is actually milder than for other age cohorts. So the mild symptoms tend to be milder as well in the 5 to 11-year-old group. And pleasingly, there is mounting evidence that the risk of myocarditis, pericarditis that we are seeing with older children and young adults doesn't appear to be a risk in this group. We have definitely seen examples, and as has the United States, in vaccinated cohorts in the 5 to 11-year-old age group of pericarditis and myocarditis, but it is in a prevalence that is the known prevalence for kids anyway as a background rate. So we don't appear to be seeing any excess risk. So I guess that means, when we're talking to people about the vaccine, we can really be quite reassuring about the level of risk in terms of side effects for children. Now, this is reasonably recent data that's been published. Tom's going to talk a bit about this from a clinical perspective. The point I wanted to make about PIMS was that we now have pretty good evidence that the vaccines are effective against PIMS. That is, if a child is vaccinated, has COVID, and then subsequently has a 91% reduced risk of PIMS. Also, if in the event that a vaccinated child catches COVID and develops PIMS, in the study that this one reports data from in the United States, none of the children actually ended up being ventilated. So I think this is actually, in reality, perhaps the most important benefit of the vaccine for children. And I do think it is worth, in talking with parents about it. I mean, I will talk about the way in which we can best talk about vaccines, but I do think this is something that people don't appreciate. They don't appreciate really how common this is. It's rare, but in real terms, when you have huge numbers of cases, it becomes reasonably common. And the other thing is that if you look at a comparator, so with meningococcal disease, for example, we have very rare instances of meningococcal disease, and yet the majority of parents are actually, rushing to be having their children vaccinated. So it's an interesting, I guess, assessment of risk that people are entering into. But it is actually helpful to make these things concrete for people so that when they're making their decisions, they're at least making them as fully informed. Oh, I'm going to go over that because Emily already talked about it. So we still hear repeatedly about a concern about long-term side effects for children. And people are tending to take the view that we haven't seen the vaccine being used for many years, and so we don't have proof that there's no long-term side effects. This one is quite tricky because really people are bringing up a potential scenario for which there's no theoretical plausibility for it. Equally, there's no evidence of any vaccine ever having had long-term side effects. And so when I have conversations with parents about this sort of issue, I do take the frame of, we're monitoring, there's no sign of side effects outside of the short window of time. And we can even say 3 months, even though that's actually quite long for a COVID vaccine. No vaccine's ever done it before. It's hard to understand how it could do it. And, I get my children vaccinated. It's that kind of framing that is really just putting kind of factual statements to people. And then a really big one, especially for certain communities, is fertility. This particularly affects parents of girls where they have heard that there will be some kind of process of sterilisation through the vaccine. So I just wanted to touch on why people are hesitant. There are actually, these reasons are pretty well generalisable to any vaccine, but concerns about safety, thinking the vaccine doesn't work or what the disease is being protected against is not serious. We're seeing all of those at the moment. But one of the really important ones, and the one that I actually think is the most fundamental, is lack of trust. So if we have communities where there's been a historical lack of trust in government, or there's a lack of trust in health services or in doctors, or they've had people with a mental illness, for example, who've undergone coercion in the treatment of their mental illness, these sorts of things actually reduce trust, and that is one of the most fundamental reasons why people don't get vaccinated. Given, for all of us, we have the scientific background. We can appraise this stuff for ourselves. We don't rely on trust necessarily to feel good about getting vaccinated or recommending vaccination. We've made a personal assessment. Whereas what we're asking of people who have very low health literacy or even very low general literacy is complete trust. Because really what we're explaining is for most people, for some people, is really beyond their ability to kind of capture, because they just haven't had a life that has given them the skills to do so. So GPs definitely have a role. Highly trusted GPs are critical in the conversation about vaccines. Sometimes as well, though, we have worked through community leaders, because it may be that even for some communities and people, either they don't have a GP that they trust, or really it needs to be someone outside of the health sector. So the other thing to really be mindful of, and I'm sure you've all seen this now, is that many people are on a spectrum of willingness to vaccinate, and most people are in the middle, where they have questions, but the questions are easily answered, and then they go ahead and get vaccinated. We're talking, what I'm about to talk about next is about people who are hesitant. So these are people who have concerns about the vaccine, and they might even be ambivalent, but they haven't decided not to be vaccinated. They just haven't been. It's really important when we're having our conversations with people that we discern between those individuals and those who've already made a decision. We find that, especially in a clinical environment, it's really important to maintain a positive relationship, and the conversations that one might have with a person who's made a definite decision not to be vaccinated, they can actually become quite unruly pretty quickly. So we do talk about really rapidly working out whether a person is open to questions and discussion, and if they are, then the next slide goes through how we might do that. I've actually really covered some of this, so I'm going to keep going. So in terms of how we should be talking to people about vaccination, this is all very obvious, but sometimes it's worth reiterating, I guess, the best practice. But because trust is a really fundamental aspect of the vaccine conversation, it's really important that when we talk about the vaccine, we talk about the benefits and we talk about the risks honestly and completely. And we also talk about what we don't know and what nobody knows. Anything that looks like we're hiding information or being biased in our delivery will actually increase the distrust. Obviously, we're trying to do these conversations in a respectful way and trying to avoid conflict. In terms of the active listening, what we're really trying to do there is try to understand for the individual that we're talking to their personal motivating factors or barriers for vaccination. And that's so that we can tie what we say to something of relevance to the individual rather than just kind of bland statements. And then the other thing is that we know that the conversations really need to be positively framed. So any kind of negative framing can cause people to become defensive and go back into their corner, and it's generally not effective. Okay, so this is a slide that I was given by Professor Julie Leask, who's really one of Australia's eminent experts in this area, and she has this kind of framework that she talks about that really is a kind of a guidance for how to have this sort of conversation. So where it begins is really making sure that we understand all the questions that an individual might have. So we might ask them, you know, what concerns do you have? They might say, I'm worried about X. And what we should try and do there is really just keep going, trying to discern all of the questions that the individual might have, rather than kind of stepping in at every concern. So once we've understood the totality of the concerns that a person has, it's really important for us to basically create some sort of agenda. So we might just say something like, perhaps we can talk about issue Y first. In our conversation with them, it is important because these are difficult conversations, and particularly so now because, you know, really the vast majority of the population's been vaccinated. It's really important to acknowledge the individual, acknowledge that they're difficult conversations, but what we're not doing is validating the concern itself, if you like. So, and when we're going to start talking about the concerns they have, rather than going, if you like, head to head with the concern they have. So they may have a significant safety concern that we know really isn't based in fact. Instead of saying to an individual, oh, well, look, that's really not true because the evidence tells us that what we would instead say is, well, from my perspective or my understanding of the issue is, and then we're going to give our worldview. I have found that even with, and I have had to have conversations that have included people who really fit the category of decided against vaccination. I found even with those individuals, it's actually a much more respectful way to deal with this potential risk of conflict, because what we're not doing is disqualifying, if you like, what a person said. We're rather now just reframing into what we would like to say about it. This also acknowledges that for many people, there might be in a community group or in an internet group, that means that they don't actually get access to a balanced information. They may only see, negative things or things that keep reinforcing, some myths about vaccination. So what we're really providing is a potential alternative for them. So we do want to actually, if we haven't understood what could potentially be a motivation to be vaccinated, we do actually want to ask people explicitly, what might encourage you? What would be a good reason to be vaccinated? So once we've done all of this, we then have an opportunity to make a recommendation to vaccinate, and that recommendation we would attempt to tailor to the individual. So if their only motivation to vaccinate, for example, is that I want to travel, then when we're making a recommendation, we would actually include that travel in the recommendation because we know it's important to you. And finally, if we've had the conversation and the individual has decided they don't want to get vaccinated now, or they're not sure, then really the task is to make sure that we leave the door open for a future conversation. So that's about saying something along the lines of, you may change your mind or you may have more questions going forward. And if you do, we'd be really happy to have a conversation again, something of that nature. What that allows is for an individual to have had a pleasant, respectful conversation. And even if they've still got more questions, they're more likely to come back for another conversation with you or with somebody else because it hasn't been attainted, they haven't felt coerced or disrespected. So, and also that means that we've maintained a good relationship with people. So I think that's actually the end of my slides, Emily.
Excellent. Thank you, Katina. That was a very informative presentation and lots of different areas that no doubt people have picked up and thought, is that why that happened? So, okay, it's a different way of thinking about things. So fabulous. And these, and we'll have your links and resources available as well afterwards, which I think will be really, really helpful to everyone here as well. Thank you. Okay, we're now going to, did you want to say something else, Katina?
No, I just wanted to work out how to stop sharing, and I've done so.
Well done. All right, we're now going to come to our special guest presenter, to talk to Dr. Tom Goddard, who's, we're very fortunate, is going to talk through around some of the paediatric aspects from the respiratory perspective and PINS TS as well. So I'm hopefully, Tom, you'll be able to open up your slides, okay?
I hope so. Can you hear me?
Fabulous, yeah.
And I'm just going to share now. Can you see? Hopefully, hang on. Is that coming up?
We can see your presenter view. Just if you just change your display settings to at the top there, we're under the.
That should
Excellent.
work. Yeah.
Perfect. Thank you.
Thank you. Thank you for the introduction and thank you for the invitation. Contrary to what it says on the Zoom meeting, I'm not Katina. I think I clicked on the wrong link. I'm sorry. So I'm actually Tom Goddard. I'm a paediatric respiratory and sleep physician at the Women's and Children's Hospital, but I also work as part of the COVID Kids service at the Women's and Children's Hospital. So that's a sort of hospital in the home and sort of virtual clinic that we run out of Women's and Children's. And we also have the capacity to assess children face-to-face where necessary. I should also say that I work part-time at Flinders Medical Centre, and I perform outreach clinics to Mount Gambier and to Alice Springs. And so I would reiterate a lot of what Katina has just spoken about in terms of communication regarding vaccine hesitancy. Certainly in 2021, as the vaccines were being rolled out, I noticed a disparity between my population of patients at Alice Springs compared to the more metropolitan patients that I was seeing here in South Australia. And that was concerning me because, as I'll show in a few slides' time, many of my patients and their families indeed were at increased risk in Alice Springs, and that surrounds the fact that they're predominantly not Caucasian and they have other comorbidities, including obesity and so on. And I should also just at the outset say that I was previously working in London until until halfway through 2020. So I was working at a tertiary centre in London at a heart and lung hospital, the Royal Brompton Hospital, in paediatrics. But after sort of March, I worked in adult ICU caring for ventilated and ECMO patients in intensive care, and so was bronchoscoping COVID patients and managing their respiratory failure, multi-organ failure. So I have a clinical experience in the alpha and beta variants predominantly, and in the pre-vaccine era. So I've seen what COVID was like before vaccines were rolled out, and so I am very grateful for the fact that Australia was able to contain the outbreak to a large extent before we managed to roll out the vaccines. So today I'll focus predominantly on PIMS-TS, which is the Paediatric Multi-System Inflammatory Syndrome, but I'll talk through a little bit about the SARS-CoV-2 or COVID-19 in children and adolescents, some of the complications that we can see. I'll give a bit of a case study, and then a little bit about the management of PIMS-TS, and cover some key points to keep in mind if and when you see children and adolescents with symptoms consistent with this. So as Katina has already outlined, the majority of children and adolescents are actually cope very well with COVID-19 infection. 80 to 90% are asymptomatic or have mild infections. Interestingly, there is some disparity between different strains. So we're seeing less of the lower airway inflammation in the Omicron variant as opposed to, say, the Delta variant. And at least anecdotally, although I don't have good data on this, there seems to be more upper airway involvement in the Omicron variant. So we're seeing a lot more children with croup-like symptoms, for example, in the younger age group. The majority of children don't need hospitalization, but we do see that of those that do need hospitalization, quite a few end up needing transfer to intensive care. And risk factors really for hospitalization and worsened morbidity and mortality include predominantly pre-existing neurological or cardiac conditions, immunosuppression, obesity, and often multiple comorbidities. So it's a similar sort of profile as you would see in the adult population, although the overall risk is lower. I think with pediatric multisystem inflammatory syndrome, which can also be called multisystem inflammatory syndrome in children, or MIS-C, this was sort of first reported in 2020, and we haven't seen much of it in Australia, at least not in the early phase of the pandemic, because the overall numbers of cases were low. But we have seen more cases in recent months, as obviously we've had a much higher denominator in terms of the number of cases spreading through the community. And so it's worth keeping this in mind, in the back of your mind when you're assessing patients. And that may also be children and adolescents who weren't identified as having COVID-19 previously, because some of them may actually be relatively mild in terms of their initial symptoms. And this is actually a sequelae of the COVID infection, and onset is typically sort of 2 to 6 weeks after the primary infection. And it's an inflammatory response which can affect the heart, the lungs, brain, skin, eyes, and so on. And it's estimated to affect roughly 1 in 2,500 children, and often results in a need for hospitalization. So this is data looking at PIMS-TS in Australia, I think pretty much up to date until the end of April. The majority of cases, as you would expect, are in the big centres, so Children's Hospital Westmead and the two large Melbourne centres. We've had some cases here in Adelaide, and there's been a few elsewhere around the country. Overall numbers are fairly low. We've had 61 cases in the last 4 months, which doesn't sound like many, but when compared to the previous 2 years of the pandemic, I think we had a roughly 35 or 36 over the first 2 years. So there's definitely been an uptick, and that just reflects, I think, the increased denominator in the community. It's roughly equal in terms of, at least in our population, in terms of female-male distribution. The average age is, or the median age is about 8 years, but we've had cases anywhere as young as 3 months up to 15 years. And risk factors include things like obesity and so on for development of PIMS-TS as well. But importantly as well, non-Caucasian ethnicity also seems to be a risk factor. And so there has been an overrepresentation of Indigenous patients in this group. Clinical features, essentially fever is a prerequisite, and typically this would occur 2 to 6 weeks after the initial infection and often lasts for days. They're often fairly non-specific symptoms and signs. Often there's abdominal pain and gastrointestinal involvement with diarrhea or vomiting. They may have a fairly generalized rash, and it can be non-blanching, similar to that seen in Kawasaki disease. And there's often conjunctival injection as well, again, similar to Kawasaki. And there does seem to be some overlap between Kawasaki disease and PIMS-TS. In this case series, this is from a large case series published in 2021, there was a report of around 50% presenting in shock and requiring inotropic support and fluid resuscitation. So, they do present very, very sick on occasion. Roughly 1 in 5 met the diagnostic criteria for Kawasaki disease on presentation. And that includes essentially, the diagnostic criteria being fever for more than 5 days, and then at least, I think, 4 in 5 of the following characteristics. So that's the conjunctival injection, the rash, the erythema of the oral and pharyngeal mucosa, and then often erythema of the hands and feet, and sometimes edema as well. And then there's often cervical lymphadenopathy. There are some clinical and laboratory characteristics that help differentiate between Kawasaki disease and toxic shock syndrome and so on. In general terms, the patients with PIMS-TS have higher inflammatory markers, so they may have a CRP more in the order of 150, 200 or above. In fact, I think in this case series, the median CRP was 229. Whereas Kawasaki is usually much lower, usually in the order of about 50 to 100. And so often the inflammatory markers are much higher in PIMS-TS, and they may not have some of the other features like the platelet count in Kawasaki disease. So we have seen some children present to the Women's and Children's Hospital with what appears to be PIMS-TS. I'll present a de-identified case of a 12-year-old boy who initially presented to the emergency department earlier this year with 3 days of fever without focus. I should state at the outset that he has an unremarkable past medical history. He wasn't overweight and doesn't have any other sort of significant comorbidities. He was assessed, his urine was tested and was found to be clear. He underwent, as with every child presenting with fever at the moment, testing for COVID, and that was negative, and he was reassured and sent home, or his family were reassured and sent home. And then they represented with 5 days of fever without focus. So this is 2 days later, and again was assessed and found to have sterile pyuria. Interestingly, also had a low blood pressure to the point where they decided to give some IV fluids, and that recovered, and then was discharged again this time with a prescription for cefalexin. 5 days after this, so at the end of his course of cefalexin, he presented to his GP, again with this ongoing fever. But on further history, he'd had some vomiting, diarrhea, he'd had some weight loss, suggesting that he'd actually been quite unwell for quite a long time. He was also complaining of some generalized back, neck, and groin pain. Blood testing organised by the GP revealed a CRP of 130, an LDH of 340, and normal blood picture and electrolyte, urea and creatinine. He had a borderline low blood pressure. On examination, a non-purulent conjunctival injection, that lymphadenopathy again, presumably the cause of his neck pain, and a systolic murmur at the left upper sternal edge. So he was referred to ED. We have adopted a similar pro forma to that shown here from the Children's Hospital in Minnesota. So they've come up with an algorithm for assessing patients suspected of having PIMS-TS or MIS-C. And so any patients with a fever of above 38 and at least 2 suggestive clinical features, so that's rash, the gastrointestinal symptoms, the hand and foot edema, conjunctivitis, and so on, are assessed, oxygen levels monitored, blood pressure to make sure they're not in shock, and then consideration of alternative etiologies, including things like Kawasaki, as I've mentioned, but also things like bacterial sepsis, toxic shock syndrome, and so on. And basically, if the patient is stable with reassuring vital signs for their age, then ordinarily we would test for COVID, obviously with PCR, but also do serology to look for past infection. And then look at other laboratory markers, in particular looking at inflammatory markers to see whether there's any indication of significant systemic inflammation. Obviously, if that's reassuring, then we would reassure, potentially discharge the patient and reevaluate over the coming days. But if on initial assessment there's any sign of shock, and low oxygen saturation, or if they're looking severely unwell, then we would look at admitting the patient. And likewise, if there are any markers on the laboratory tests, then we would look at hospital admission and management from there. So that's the rough pro forma. Our boy was referred back to, or referred to the Women's and Children's Hospital. I should say the initial emergency department presentation wasn't at the Women's and Children's. And was assessed at the Women's and Children's. Again, had a number of blood tests performed, including blood cultures, had a CRP of 145, reassuringly low procalcitonin, suggesting that this wasn't bacterial sepsis, but there was clearly inflammation going on. Although his PCR was negative for COVID, he had antibodies detected. And the remainder of his blood tests, including things like troponin, D-dimer, platelets, and coagulation studies, and so on, were all normal. He was discussed with relevant inpatient teams, and a decision was made, obviously, to admit and to treat. But the question was this PIMS-TS or was this Kawasaki disease? Because some of the features that this boy had would meet Kawasaki disease, albeit his age would suggest that he's outside the classic age range for this condition. So he was admitted for intravenous antibiotics, so sort of empirical therapy. He had immunoglobulin, aspirin, and analgesia. The aspirin being to try and reduce the risk of coronary artery aneurysm, which is seen in Kawasaki disease, but also has a rate of about 15 to 25% in PIMS-TS. So up to a quarter of patients with PIMS-TS may develop aneurysm in the coronary arteries, and so that's a significant risk factor as well. So reassuringly, he improved over 3 days with the IV antibiotics and the immunoglobulin therapy. His blood cultures were clear and his fevers settled with that. His echocardiogram was normal, so there was no coronary artery dilatation, and his serial CRP numbers dropped over the ensuing 3 days. He was actually discharged home with daily aspirin for approximately 4 to 6 weeks until review with cardiology with a repeat echocardiogram. And so this is still pending. I don't know what the result of this is. but there is the possibility for longer term development of coronary artery aneurysm. So this is hopefully being monitored. So in all likelihood, he avoided some of the more concerning sequelae from PIMS-TS, if that is indeed what he had, and we assume that this is the case. Not all patients present this way, so he's a little bit atypical in that most of the ones presenting with that Kawasaki-like phenotype, most of the patients that present in this way actually are in the younger age group. They're typically under 5 years of age. Indeed, more commonly in his age group, they tend to present with a shock-like presentation, and it may be that he was partially treated with cefalexin and some anti-inflammatory medication in the home, and that may be why he avoided a worsening of the presentation after that initial presentation requiring fluids 5 days before his admission. But oftentimes they will present just with an undefined inflammatory presentation without necessarily having the shock, but with some of the features of the Kawasaki disease without meeting all the criteria. So I think really the key points from the PIMS-TS point of view is that we know that SARS-CoV-2 or COVID-19 can cause morbidity and mortality in children and adolescents, but thankfully serious sequelae are much rarer in children and adolescents than they are in adults. However, I think with the thousands upon thousands of cases that we're seeing, we do run the risk of missing serious complications from this, simply because the denominator is so high. It's likely that we will see some children and adolescents presenting with these sorts of complications. I think we need to consider PIMS-TS in a febrile child with any of the following: with a rash, a sort of generalized sort of morbilliform rash that's often non-blanching, a conjunctival injection, abdominal symptoms of pain, vomiting, diarrhea, and any features of shock, so tachycardia or hypertension for age. And we know that early recognition and treatment for this condition actually improves outcomes and avoids the need for ventilation or further support in terms of ECMO and so on. And we also know that the evidence suggests that empirical therapy for sepsis is needed, because diagnosis of this condition is clinical and on a sort of an array of tests rather than having a single diagnostic test. And so we need to keep a differential diagnosis open and treat for those sorts of conditions that could otherwise be missed before we start to consider specific therapies such as IVIG and anti-inflammatory therapy like aspirin. So I think that is what I'd like to highlight with PIMS-TS. I would also like to highlight that the picture is changing. We're finding out more information as we go along about all these variants. I think we do see, as I mentioned before, quite a lot of upper respiratory complication. We're seeing quite a lot of gastrointestinal complications, a lot of children being dehydrated, and in actual fact that's probably the leading cause of admission to hospital is dehydration, and so they're not tolerating oral intake and they're having increased rates of vomiting and diarrhea. Interestingly, the rate of asthma exacerbations seems to be lower. The initial data, certainly coming out of Europe and North America on Omicron, seems to suggest that the Omicron variant isn't a significant trigger for severe asthma. And certainly, it's in comparison with RSV or influenza, it's probably less of a risk for asthmatic patients. But that may just reflect the fact that it's causing less lower airway inflammation and more upper respiratory tract inflammation. And there are other sequelae that we're only just starting to find out about. So, things like type 1 diabetes. COVID-19 does seem to be able to trigger or at least unmask type 1 diabetes in children and adolescents. And there is some interesting data coming out on this field as well. So there are other sort of longer term effects from this infective process that we're only just starting to learn about. And I think this is an area that's going to change and continue to change over the coming years. And when I think back to 2020 and the situation sort of even before testing was really widely available, and then vaccination was eventually rolled out, there have been huge advances in terms of treatment. And so I think we're understanding more and more each week on this new disease and the effects it has long term. So I'd be keen, if there are questions. I think there are questions in the Q&A section. I can answer some of them. So Karen Fuller's asked, is the croup more severe with COVID? I don't think there's any evidence for that. We're seeing relatively higher rates of croup with Omicron than we did with previous variants, but I don't think it's necessarily more severe. And it certainly seems to be triggering croup in those patients that may already have had croup before. But there's not a lot of data, to my knowledge, in this area. Regarding his vaccination status, he was unvaccinated. So that was Nazila's question. And we know in terms of treatment for acute COVID, that we would have a much lower threshold for using Paxlovid and other treatments in the unvaccinated population, because those who are unvaccinated with risk factors are much more likely to progress to developing significant morbidity and mortality. And unfortunately, that's what we saw in the UK when we were involved in the initial months of the pandemic. Vaccination does seem to reduce, at least the initial data suggests that it does reduce the risk of developing PIMS-TS, but again, this is something that I think we'll learn more about as we go along. So that was Chua's question. And I think overall, it probably, if it behaves if vaccination affects PIMS-TS in the same way as it affects other sort of generalized complications of COVID, I would expect it to reduce the severity of the episodes as well. But again, this is an area that we're still learning about, and certainly in Australia, we don't really have the numbers of cases to be able to answer some of these questions yet.
Fabulous. You've really covered some really key areas. So thank you so much, Tom. And I think as well, having your experience as well in the UK has been so valuable. It's been incredibly lucky to have you here in South Australia as well. Particularly, I just wanted to then also just touch a little bit around the COVID kids model, if that's okay. You mentioned briefly just then about Paxlovid. Are you using much in terms of the oral therapies or in terms of IV treatments in children at this stage here in?
Not huge numbers. We are using it prophylactically in a number of patients. Usually those that are at high risk. So when I say prophylactically, they're diagnosed with COVID-19, but before they're developing significant symptoms. Often it's in the immunosuppressed patient group or the unvaccinated patient group with multiple comorbidities. So there is similar criteria, I think, to the adult model. But thankfully, we haven't had huge numbers requiring treatment. The benefit of and again, the treatment space has changed significantly with the new variants as well, and with the increased knowledge that we have in the pediatric and adolescent sphere. So remdesivir, for example, doesn't appear to be effective for the Omicron variant in our patient group, so we're not using that so much anymore. We are using Paxlovid. We are using some adjuvant therapy, steroid and inhaled therapies for those with severe asthma and other respiratory conditions that may benefit from additional therapy when it's picked up early. But in general terms, the majority of children, even when they do have some predisposing factors, have coped very well. And to my knowledge, we haven't had any deaths specific to PIMS-TS in this state. Although, correct me if I'm wrong. We have had, I think, a couple of patients or children who have died with COVID, but not necessarily because of COVID. And I don't know the exact details for those cases, but I think we've actually managed the pandemic very well up until this point. In particular, when I compare it to the sorts of things that were going on overseas, and when I look at my colleagues and what they've had to deal with over the last 2 or 3 years in Europe, UK, and North America, I think we've been very lucky to avoid some of the effects on an individual level, but also on a health system level. I think we've managed to avoid a lot of the side effects from having a huge wave of very sick patients. And one of the problems that I was dealing with in the UK was that a lot of the patients that I should have been seeing with end-stage lung disease or interstitial lung disease or cystic fibrosis and those sorts of conditions, they just weren't able to be seen, and there were patients dying of preventable complications from those conditions because we weren't able to provide the care that we should have been able to provide. So I think we've been very lucky, I think, here.
Yeah, absolutely. Yeah, very devastating for our colleagues overseas and for what we've seen with the communities overseas as well. The other area I did want to touch on, and I know we've had a couple of questions around the third dose. I don't know, Katina, if you want to touch on this around the third dose. Is it likely that we'll see that in 5 to 11-year-olds emerge?
We're taking punts, really, aren't we? So not being a member of ATAGI, this is not definitive, but I guess what I would say is the reason for embarking on a third dose would really be more about severity of illness. So if we know we've got kids with the 2 doses, but actually the protection against severity of illness, protection against things like PIMS, TS holds, and it certainly looks like it's holding now, it would be hard to imagine that they would add a third dose for kids. I mean, I do think that there would be a role, and I'm sure that it'll come out about immunocompromised kids where the vaccines may not have worked all that effectively in the first instance. So there may be special groups, but my guess is that wouldn't happen. I can't imagine too that we're having such trouble getting kids vaccinated with the primary course. Even if it was available, I'm not sure how much of it would actually be taken up. I don't know, Emily, is that your punt as well?
Yeah. Yeah, absolutely. And I think I guess the discussion is now as well around some of the newer vaccines that are being developed to enable them to be responsive for variants. There was a forum earlier in the week, it was Monday, with the with Israel to talk through around, it was a joint Department of Health Israel meeting to talk through around some of the findings that were coming out, particularly around 4th doses. And this was related to the data that initially came from the 3rd dose. And how effective the vaccines have been. And certainly the messaging from that was that we wouldn't be looking at rolling out a 4th dose population-wide here in Australia, given that it's not really made a big difference at all for Israel. It was just quite interesting. The other aspect of this is long COVID as well, and some of the impacts of vaccination on long COVID, but more from the paediatric point of view. We don't really hear a lot about long COVID in kids. I don't know, Tom, if you've heard much around, particularly here in SA, but also from overseas around, are we seeing much in terms of long COVID, particularly now with the Omicron variant?
Yeah, I'm not sure about the Omicron variant, but there are certainly reports of long COVID in children and adolescents, probably more commonly in adolescents than in younger children. We have we have had seemingly some cases here in South Australia. And one thing that I don't know that we've really got a good way of capturing is how, who are those patients and how are we going to follow them up? I think that is something that we probably ought to be looking at, whether that falls under the sort of COVID kids umbrella or not. I think the COVID kids model is much more focused on the acute phase of the illness, and really some of the sequelae from long COVID probably warrant a more of a multidisciplinary approach to management. It would be my impression. but again, it's one of those areas that I think we're going to learn more about with time. But it is something that is of concern for a number of families, and one of the reasons why some families are keen to vaccinate their children. I think the other thing I would say, again, I mean, Katina spoke very well about this, is the level of trust in different parts of the community. And that's something that I saw actually up in the Northern Territory in Central Australia, was that there was really big variation between different communities within, I'm talking Indigenous communities, but different communities had different understandings and different, much different levels of vaccine uptake. So some communities I was seeing were 90-95% vaccinated, others were 30% vaccinated. And again, that was, to my understanding, around their level of trust in Aboriginal health workers, in GPs, in nurses and so on, who were working out in community. And in some communities, unfortunately, there wasn't that level of trust, and that, I think, has meant that some communities haven't been protected to the same degree. But I think, I think anything we can do to try and encourage people to get vaccinated is only going to be a benefit.
Absolutely. All right, that's really the end of our questions that have been posed. I'll open up any final comments. Katina, any final words you'd like to send across to our GP?
Really just, I guess that opportunity. Perhaps I could give you an example of a primary healthcare service where they're actually achieving greater vaccination rates than the general population. I won't name where it is, but really what they're doing is actually, if you like, basic high quality. Not to say that high quality is basic, but what we know is high quality primary healthcare. So it's recall systems. So knowing who's been vaccinated in your patient population and recalling them to the clinic, knowing when the person arrives to the clinic for another purpose, taking that opportunity. So it's those opportunities, also opportunities with parents, even if the kids aren't there. So it's the kind of repeated all the time approach that seems to be working. I mean, we won't reach 95%, I don't think, but we definitely could be pushing higher, because we know we have some communities, for example, in the Anangu lands in the north, children are above 70%. So they're outstripping the kind of general rate across the state. So, and what they've been doing there is stuff that's actually tricky to do here, like door to door, but they are using trusted people in the community as the message. They are using recall systems. They are making it a everyday, all day responsibility of the clinic. So when people turn up for other purposes, then vaccines is offered. Thanks.
Thanks, Katina. Thank you. And Tom, any final words you'd like to send across?
No, I guess the only thing I would say is that I'm very worried about the coming winter and the flu season. I haven't experienced winters like the last one in Australia. It was very unusual in that we didn't see many cases of flu at all, or in fact much in the way of respiratory viral illness in children. And I suspect we're going to get a much larger season this season. So I would encourage people to get vaccinated, and for GPs and other health professionals to be proactive in encouraging them. I see a skewed population, obviously, with underlying respiratory conditions, but anything we can do to try and minimize risk in this area is going to be important as well. And then I'm also worried about the potential for co-infection with COVID and flu at the same time. So that would be my warning, I guess.
I think I saw the data that came through this week. We're still at 5% of children aged 6 months to 5 years under the NIP from both public and private GP administered flu vaccines, which is just a dismal number. We are 6 weeks into the program, but it would just be, I guess it's a little bit concerning that's the uptake we've seen so far. And we do know currently that general practices are really quite overwhelmed at the moment in terms of finding capacity and bookings. So there needs to be other opportunities. We have the schools-based COVID program, which has been which has been actively promoted by our current government. We're just working through the details of that at the moment. But even the issues around consent and being able to create a schools-based program has been incredibly difficult to be able to achieve. And so we've put forward, is that something we could look at with influenza vaccines? But it just seems incredibly bureaucratically troubling to be able to get to it to be able to roll out a comprehensive flu program to children. But yes, I agree, this is going to be problematic for us as we come into the winter months if we don't have other ways that we can support vaccination. So we need to do what we can with COVID vaccines, but of course, I'm sure, Katina, you're already thinking about this. Have you got any other programs that you're working on for influenza with this as well?
So, I mean, just more in terms of how we talk about the vaccine and the building confidence in vaccination. So that's now a new thing with, lay groups. But yeah, so in terms of, we haven't worked out though whether, for example, vaccine buses, which traditionally have only had one type of vaccine on them because of the risk involved and they're really not clinical environments. So I think we do have some limitations in pairing them in the model that we use in vaccine hesitancy, which is taking a vaccine to an individual. I mean, that beautiful dual vaccine of the COVID and influenza in one is really what we're waiting for that.
Absolutely. Well, this has been a fantastic webinar, and I'm sure we'll have many views online afterwards this evening. We gave only a short period of notice for this webinar going live, but we do find that most of our views do come from people watching them in their own time at home. So we're incredibly grateful for our two fantastic speakers this evening, to Professor Katina Denisi and to Dr. Tom Goddard. And again, a very big thank you as well to Adelaide PHN for hosting tonight's webinar, and for Brendan for being so flexible when we come up with ideas and topics that we want to present. And this was a key one around PIMS-TS, vaccine hesitancy. We're very grateful for Adelaide PHN's support in enabling us to present tonight's webinar out to GPs. So thank you.
Thank you all.
Thanks very much.
Thank you very much.
I just want to thank everyone for their time tonight, and really appreciate you coming on and speaking to the general practitioners about all this information. It's been wonderful and fantastic. So thanks again, everyone.
Excellent. Thank you. Good evening.
Thank you.